All right. All right. Well, thanks for jumping on here this afternoon for this exciting new opportunity through the Rural Health Transformation Program. We'll get into what that is in a minute here. Um, if you have questions as we go along the way, you can either enter things into the chat interface or there's a Q&A interface as well. You can load up questions there and I'll address them at the end and leave some time. This is just going to be a very high level overview of the funding opportunity that's going to be going live here soon. Um, Additional details will become available when we go live with the RFP, and we'll discuss some timelines a little bit later here in the presentation. For those of you who don't know me, I'm Charles Souchere. I'm the Deputy Director of Ambulance Services, and I'm going to be kind of the Office of EMS point lead for this Rural Health Transformation Project program, this treatment in place pilot program. And so we will get started here. This is just some required federal language on funding and where it is coming from. The Rural Health Transformation Program is supported through the Center for Medicare and Medicaid Services. That is just required language. We'll skip ahead here. What we'll touch on today is introduce you to what the RHTP and Treatment in Place Pilot Program are, what the application process is going to be, some deadlines, and then we'll leave time for questions at the end. All right, so what is the Rural Health Transformation Program? So in 2025, on July 4th, the RHTP was created by federal law. It was part of the One Big Beautiful Bill package, if folks remember that. It's intended to help states support rural communities to improve access to healthcare, quality, and outcomes. And so the whole goal of it was to target rural communities and improve healthcare for them. They are trying to do this through like coming up with new ideas, such as this treatment in place pilot program, strengthening strategic partnerships, developing infrastructure, and encouraging workforce development. Nationally, the program is going to provide about $50 billion to states over the next 5 budget periods. So it's a pretty big undertaking. The Minnesota Department of Health is the lead agency that's heading up the RHTP program in Minnesota. They were awarded $193 million from CMS for the first budget period. If you're interested in what the specifics, it covers a wide, the project plan that they got approved for covers a wide range of topics, including this treatment in place program for EMS. And if you want to read that full narrative, it's available on their website. You can find it pretty easily through a Google search. But it's a pretty lengthy document with lots of components. And so if you want to dig into that deeper, you can certainly check that out on their website. Of that 193 million, 9 million has been dedicated to a treatment in place pilot program that's going to be managed by the Office of EMS. All right, so what is this treatment in place program? So this TIP program is going to be a pilot system to reimburse ambulance services for 911 responses that result in patient care, but do not require transport to the hospital. So this might sound similar to the rural uncompensated care pool. There's some technical differences, but the idea behind this is that an ambulance service could go out to a patient, offer to treat them at home instead of transporting them to the hospital, and then still get paid through this program to cover some of the cost. It's not going to be like the full amount of a 911 call or an average cost, but to recoup some of that money for those lower acuity patients that could be managed at home and wouldn't necessarily need to go to the hospital, except that the only way that you guys get paid is if you transport them to the hospital. So the goal is to reduce unnecessary transports to emergency departments and support patients at home, while providing some funding back to the ambulance services to cover the cost of running those calls. All right, what do we mean by treatment in place? So the definition of treatment in place for this program refers to a clinically meaningful assessment and/or intervention performed by licensed EMS personnel in response to a 911 call in accordance with the agency's medical director approved protocols that results in a documented medical decision not to transport the patient by ambulance. What does that mean? That's a lot of words. So these treatment in place calls are going to be more than just sort of like your, I don't know, like you went on a call, there was no patient contact and you left. You're not going to be able to get paid for those kinds of calls. This is the call where you go, you assess your patient, you document your physical assessment, you're documenting vital signs, and documenting that medical decision making. That's going to be the key component of this here. So it's a little bit of a shift. We're going to need to see documentation that options were discussed with the patient. You offered to treat them at home rather than transport to the ED. And they said, okay, yes, I'd rather do that. I don't want to go to the hospital. And so this is where you're taking advantage of that and submitting this call for reimbursement. This is a big shift in how EMS sees its role. You know, most of us are used to a you call, we haul model, and we can relate, you know, and that's how we get paid. So this is trying to shift that burden. And I think most of us that have worked as clinicians can relate to those patients that, you know, we have the tools to treat, but our protocols don't really allow us to treat that person unless we take them to the emergency room. This is kind of expanding that idea that some people can be treated at home and then not be transported to the hospital. And, you know, what that follow-up care looks like, you can work on that with your medical director, or, you know, they take care of themselves at home and hopefully we've solved their problem. And this program's designed to offer some compensation for care provided to the patient, like I said, even when they're not taken to the ED. So who qualifies to apply to be in the program? We developed a definition of rurality that's based on existing statute, and we wanted to be inclusive as possible. So we settled on a rural service being any licensee who primarily provides ambulance service outside the 7 metropolitan counties identified in Minnesota state statute. On the map here, you can see the 7 counties flagged in red here. So that leaves a pretty broad swath of the state for services that are eligible to apply to participate in this program. Some, I know this is maybe just a handful, and I don't know if any of those folks are on the phone here, but if you're a metro-based service, but you own licenses that are outside of the metro area, you would qualify to submit those licenses that are outside the metro area, the metro counties, to be included in the program. It just would not be calls from PSAs that are within one of the 7 counties. All right. So what are we talking about for reimbursement? How much can you get paid? The amount settled on this is going to be $500 per qualifying call. You can get reimbursed. That number it's about 70% of the average cost per run from the 2026 financial evaluation. That's from the data that you guys all submitted to the Office of EMS. This is, you know, this program was not intended to like undermine transport to the hospital. And so we wanted to make sure that there wasn't a financial incentive to try to leave people behind. And so we know that in normal cases, you're not going to be getting any money for patients that you treat but don't transport to the hospital. And in this case, you'd be able to recoup at least some of the cost of those non-transports. Unlike the rural health or the rural uncompensated care pool grant money that has been going out, there is no upper limit to this except what you guys put in your budget. So part of your application is going to require you to develop a projected amount of how many treatment in place calls you think you might go on. And then you get reimbursed $500 per call up to the maximum amount that's been listed in the contract. As opposed to the uncompensated care pool program, which capped out at 200 runs per service. And then the amount per run that you got was limited based on the total pool, you know, the number that was being submitted to the total pool. So this will be $500 per qualifying call up to your maximum projected budget. All right, what's the application process going to look like? It's going to be a form stack application that'll be available on the website for OEMS. It's going to consist of questions and narratives where you'll have to explain the program that you guys will be creating. You're going to need to submit a budget and then a work plan. OEMS is going to review the calls for eligibility and issue payments. So the calls that you then submit for reimbursement, we're going to review those and then issue payments through the SWIFT system to get you that money. You're going to have to work with your medical director to develop treatment in place protocols and a plan for training staff before they go live with the treatment in place program. Like I said, this is a shift of, a big shift. It's going to require folks to document more than perhaps they're used to documenting on signatures, because we need to see like a very thought out, documented decision making in order to we want to make sure that the patients are being fully assessed and treated, both to reduce the level of risk of leaving patients at home, but also ensure that they're actually getting care and not just a cursory assessment before deciding whether or not to leave them. You'll also need a letter of support from your medical director for your application. So you'll want to keep that in mind if it's sometimes tough to get a hold of your medical director. Reporting requirements. So monthly services participating in the program are going to have to submit a list of the calls that they are trying to get reimbursed for. Those are going to be submitted through an online form. We'll also need short progress reports. This will all be laid out with additional information as the programs go live. But there'll be monthly reporting, and then we'll be reimbursing you for those runs as we review them. There is a program evaluation component of this that the Department of Health is going to be conducting. You guys won't have to do any additional data submission other than your patient care charts that you're already submitting to MinStar through the Elite platform. So you guys are going to chart, your best on these, and then we will be pulling that data to try to see, like, are we reducing the number of patients being transported or low acuity patients being transported to EDs, kind of some of the benchmarks that have been set through the program design. All right, some important dates to remember. End of June, early July, I'll throw this out there, but I'm going to make it a tentative, but we're looking at July 6th for the go live date for the RFP. Mid-July, there'll be a grant applicant informational webinar. This will be put on by our grants and finance folks. Applicants who are working on their applications, they can come and ask questions, get clarifications, and then we'll document all those questions and then post them online so that everybody has access to them. But there will be an interactive webinar where you guys can ask questions about your applications. And then early to mid-August, applications will be due. And we hope to have things reviewed and finalized by October to get these programs up and running. Next steps. Start thinking on your services capacity and interest. So we'd love to include as many people as we can. We know that sort of the grant management process is different for a lot of our services. There's not been this kind of money available for EMS before. So this is a little bit new. Our staff is here to help you with whatever you need, but start thinking on your capacity and your services interest. Engage with your medical director to see if you can get their support if you're interested in doing this, because you're going to need to develop protocols and a training program to ensure that folks are up to speed on what this looks like and how this is different from normal operations. So those are two things that you are going to want to kind of get the ball rolling on here. Okay, like I said, very high level overview. Look for our website for more, and we'll be sending out additional emails. You should have all gotten the Gov delivery announcement that had our Minnesota Rural Health Transformation logo on it. That's going to be the vehicle for most of our communication, so we'll continue to send that stuff out via email. So keep your eyes peeled for those. If you have questions or anything for me, this is my contact information right here. So don't hesitate to reach out. And then I'm happy to take any questions. You can raise your hand and I can take you off mute. You can put it in the chat, or you can use the Q&A interface in your Teams. Hi, Tom. the application and stuff will be handled through a separate place, separate from the Minnesota Grants Portal. Our agency doesn't have access to that, so we'll be using our own kind of form stack applications interface to do the reporting. A question, the presentation is going to be posted on the YouTube page, so if you want to catch it there later, you can certainly check it out there. All right, I see a hand up. John. You should be able to unmute yourself now.
All right, there we go. How about now? All right. Is this in addition to any treat and place or treat no transport fees we may be charging to the patient or their insurance? Or is this going to have to be, would this be the only funding for that run that we'd be allowed to use?
You know, that is actually a good question. I believe I'm going to dig into that with Department of Health and let me get back to you, John. I am not sure if that is, you know, I know the rural uncompensated care pool, you couldn't have gotten paid by any other thing, but this is different. So I don't know if you charge fees, if that would exclude that run.
Right, because yeah, this would, if I got paid on this out of this grant program, that probably wouldn't let me qualify for the uncompensated care pool. But I'm curious as if we're already charging a transport not resulting in or a response not resulting in a transport, whatever the new phrase is. Anyway, thank you.
Yeah. Okay. Thanks, John. All right, so there's a question in the chat. It says, we have a lot of lift assists. We evaluate, help up, assess after, and then decide to transport or not. Is this too low of service to apply to this program? Nope, Darcy, those are the kinds of calls. It's going to be important on how you document those runs. So there's got to be a good documented assessment, a complete set of vital signs, and then a nice narrative describing, you know, your medical decision-making and you know, your medical decision making, and then that final decision whether to not transport. All right, and another question: will this interfere if our organizations applied for our own rural health transformation grants? This is I'm not sure how to answer that question. This is a separate pilot program. If you're participating in this, those kinds of questions should be directed back to probably to CMS about your application. All right. And I think that's Alex Catavinas. Go ahead. Go ahead, Alex.
Yes, sir. I missed the part about I'm assuming it's individual license holders through the ambulance services that are outside of the metro counties. So I guess first question.
Yeah, so eligible services are any licensed ambulance service with primary service area predominantly outside of the 7 metro counties.
Okay. Follow on to that is, I guess, kind of for the consortium that's down here in the Southeast, are we able to consolidate an RFP if we have multiple services to streamline things and kind of hold on to that RFP process? I just asked because I know I'm able to kind of do things a little more outside of the box and take some of that from the service directors that aren't full-time. I just didn't know if that could potentially be an option to lump them together for you guys.
I will bring that back and get back to you, Alex. That's a good question. I know. Yeah, that's a good question. I'm not sure if there's a way for us to kind of bundle those things because the payments have to go to individual, like SWIFT accounts.
Yeah. No, and if you could just figure out at least the pre-grants, you know, pre-stuff can come through the office, and I don't know. If you can look at it, just let me know, Charlie. I appreciate it.
Yep, will do.
Thanks.
And all right, Adam Harvey.
Yeah, just kind of a follow-up to my question there. So, like I said, it was more just obviously every rural organization had the capability to apply for that federal rural health transformation grant. So my CFO and CMO both asked, because apparently there were very strict rules on it, are we actually applying for this, or are we working with OEMS? So is this your grant basically, and then we're just reporting back to you versus back to CMS? Because that's kind of what this comes down to.
Yeah, so the Office of EMS is a sub-grantee from Department of Health, who is the direct grant recipient from CMS. So services will report to the Office of EMS. We report back to MDH, and MDH deals with the CMS side.
Okay, thank you.
All right. All right, I'm going to give it a few more beats here for any additional questions before drawing to an end. All right, one last thing that I will say is in order to make sure that you guys are getting the most up-to-date comments, double check your demographics in your e-license accounts for your agencies and ensure that that contact email in there is up-to-date and current. That way, when we pull our email lists, we'll be sure to make sure we're getting it to the right people at the right time. All right, thanks everybody. Oop, hang on, we just had one. Hi, Deb. Yep, keep your eye on the website for FAQs and anything. We'll be posting additional information there as we update the page, the web page for this grant opportunity. All right, thanks everybody. We're going to leave it there. Next week, the application RFP should get posted, and please check it out. All right, thank you. Bye-bye.